absolutely. So it's a great pleasure to be here with you remotely, unfortunately. I did want to come, but the situation is obviously very different now in the Middle East. But I'm very happy to join you and to listen to your very interesting lectures. So we're going to talk about lifetime management of patients with valvular disease, which is a very hot topic, important issue. So many considerations we have related to that topic, and it's a new topic. It's a relatively new topic because at the beginning we viewed valve implantation, transcatheter valve implantations very differently. We wanted acute success and not to look at the long term of each of our patients. But we need to understand these are my conflicts. We must understand that when we talk about lifetime management, that there is something that is related to it dramatically, and it is the remaining years to live for our patients, or life expectancy. And we need to understand that life expectancy in 2025 is very different than life expectancy even 20 or 30 years ago. This is a graph of world life expectancy over the years. And this is how it looks in recent decades. And there is a big difference when we talk about life expectancy of 50 or 60 or 70 years, or nowadays in Israel and in Greece, it's about the same. It's early 80s. Early 80s, many patients will be 90, and some patients will be 100. So life expectancy drives us to think about the long-term considerations, lifetime management of our patients with valve disease. Because when we talk about patients that are very old and can get very old, the remaining years to live it's a significant number. A 65-year-old nowadays can live on average 20, 25 years. An 80-year-old would live more than 10 years. This is a significant number. I'm not going to show you what the number of patients above the age of 90, number of people above the age of 90 in Israel. Israel is not a huge country. It's more than 100,000 people above the age of 90. And there are tens of thousands above the age of 100. So it's clear that there are many, many extremely old patients that are on our way. And when we talk about not 75-year-olds, but very old people, we need to think about illnesses related to very old people. So coronary calcification and methods to treat coronary calcifications, hearing aids, dementia, degenerative joint disease. There are so many illnesses that are related to that fact. And also in our field, it is severe aortic valve stenosis. Also, by the way, mitral annulus calcification, mitral stenosis. These are the diseases that we will encounter in the future. And it is amazing when you see in the internet so many things that are related to the fact that people live longer. There are like Olympic Games for very old people. I'm not sure if you know. There is a guy that you can see him like doing long jump. They didn't show what happens after he jumps, but it's really interesting the fact that people nowadays live longer. Another consideration that is somewhat related to lifetime management is under-treatment. We know that many people are not treated for their valve disease. This is a survey that was performed in Israel a couple of years ago. In the x-axis is the age of people. The y-axis is number of patients. We see from that survey that there are many, many people, especially old people, that will never be treated for their valve disease. And that issue is related in some way to lifetime management, because when we implant our valves and they degenerate, In many of these patients, we will never know that they have degenerated. We need also to remember that the main devices to be used for valve treatment were mechanical valves, not a century ago. It was 25 years ago, in late 90s, the main devices were mechanical valves. These devices work well, but unfortunately, Coumadin treatment, obligatory Coumadin treatment, does not allow for their common use. And we see over the years the transition from mechanical valves towards bioprosthetic valves. And when we talk about bioprosthetic valves and the increase in bioprosthetic valves and the TAVI field that includes currently only tissue valves, we understand that we have entered a new era. We have entered the tissue valve era. It started in the around early 2000 years, and 2010 maybe it became very dramatic, and the TAVI field is part of the tissue valve era. In 2006, the majority of cases that were performed were with tissue valves already. Surgical AVR. In 2010, 85%. In 2016, there is a new player in the market, 30% of TAVR devices, mechanical valves only 10%. And currently, mechanical valves, I don't know the numbers, the exact numbers in Greece, but it's around 5% in most Western society countries. The tissue valve era includes many devices, surgical valve devices, stented valves, stentless valves, rapid deployment valves, and also transcatheter valves, balloon expendable, self-expendables. There are many devices. Some of them are surgically inserted, some are transcatheter inserted, but there is one major limitation for all of these tissue valves that is ubiquitous for all of them. It is the structural valve degeneration. If we could have eliminated SVD or structural valve degeneration, I'm not sure what it would have done to the industry. There would have been much less bioprosthetic valves that would be required, but obviously it would have done extremely well for our patients. They would have implanted with, in many of these cases, one valve for the rest of their lives. But unfortunately, SVD is a significant illness. It's becoming a very common illness because there are many patients implanted with tissue valves. We need to understand that bioprosthetic valve dysfunction includes many options. It's not only SVD. It's not only structural valve degeneration or deterioration. There are also non-SVD situations like prosthetic patient mismatch, like paravalvular leakage, like malposition. There are thrombosis cases, and there are endocarditis cases that we cannot exclude. So there are many etiologies and reasons for bioprosthetic valve dysfunction. But a meaningful part of that dysfunction is because of structural valve degeneration or SVD. In the past, SVD was defined in a binary way. Not long ago, only a decade ago, people in different definitions and papers and consensus documents regarded SVD as binary phenomenon. It's either you have or not have SVD. In many cases, SVD was the need for reoperation for a failed valve. This is what we see in all literature of surgical valves. But obviously, like when we grade the MR or TR or AS, we grade it in stages. SVD should be graded in stages as well. There is limited SVD and there is high degree of SVD, and obviously these patients should be treated differently. This is from VARC 3, which went into that topic more depth. There are clear definitions on how we define SVD, and basically different devices should be described accordingly, how they are behaving in 5 years, in 10 years, and eventually we're heading there. Not in many years, in a few years, we will see comparisons between different devices and the rate of SVD in a meaningful number of cases, and we can understand whether one device has a better durability than the other. And when we talk about valve degeneration, we need to understand that there are risk factors. There are risk factors for valve degeneration. Obviously, younger people, they degenerate tissue valves more quickly. Tricuspid and mitral positions degenerate more quickly than aortic position. There are devices that degenerate more quickly as well. And there are other risk factors that will not go into all of them. And there is that sexy, a very complex question whether TAVR devices degenerate more quickly than surgical devices. And it's a complex question. There are, you can see in the literature, many bench testing, many physical assessments of TAVR and surgical valve devices. But we can say, in general, when we look at that topic, zoom out, that there are hypothetical reasons for reduced TAVI durability. Some of them are related to the characteristics of the devices. Some of them are related to how we deploy these devices, and some of them are related to the interaction between the device and the anatomy. And basically, all TAVI devices are, hypothetically at least, prone for valve degeneration. First, we deploy these devices through small sheaths. We inflate balloons inside them. We change them in some way, or we apply some physical force into them. And the second thing is the lack of native leaflet decalcification. When there is surgical AVR, there is always, almost always, removal of the diseased leaflets before you deploy the newly implanted valve. So these topics are being evaluated nowadays, and we try to understand, but it is also clear that devices are different. So here we can see 6 surgical AVR devices. They are very different. Can we say this is SAVR and the durability of SAVR is like this or that? These are different devices. And we can also look at these devices and say, this is TAVI or TAVR, and the durability of TAVR is this or that. But actually, it's nonsense, right? Because these surgical devices were different, and these TAVI devices are different, and it's not going to be surprising that their durability is going to be different because these are different devices. And with time, we understand more and more about this topic. But it is clear also that the burden of proof that is applied to TAVI devices is very different, especially in the US. It's very different when we talk about TAVI in comparison to surgery. You can have a new device, surgical device, and the burden of proof to implant it in 50-year-old, 45-year-old would be very minimal. But when we talk about TAVI device, you need huge studies, huge trials in order to show that these are successful devices. But with time, we see that eventually the community moves towards TAVI. So there are some studies looking at durability and comparing TAVI and surgery. Obviously, I'm not going to show everything. It's still one lecture. But the Notion is probably the most important of them. Notion used the self-expandable devices of Medtronic and compared them to surgical implantation. And basically, we don't see difference in meaningful outcomes between the two strategies. We do see some signals that are actually in favor of TAVI when we compare that to surgery. There is much less severe prosthetic patient mismatch when we use TAVI devices in comparison to surgical devices. And in some way that translates into better hemodynamics and maybe better durability, but we can say at least that with the self-expandable supraannular devices platform, there is no limitation of durability in comparison to surgical devices. And TAVI today is very different than TAVI in the NOTION study that used mainly core valve devices, and also different than TAVI 3 years ago. TAVI is a cath lab procedure. We do procedures under conscious sedation almost always, relatively small sheaths, no rehabilitation is required. PVL rate that we were concerned with in the early days is not significant. Pacemaker rate is decreasing with time over the years. So we see that modern TAVI procedures are probably going to be much easier to perform, and they are maybe will have better long-term outcomes. We have several big studies on low-risk severe aortic stenosis patients. The most meaningful are the PARTNER 3 and the EVOLUTE low-risk trial. I'll not describe them in long, but they are all related to the lifetime management of our patients and decisions about whether to use the surgical approach or the TAVI approach when we think about the long term of our patients. But basically, at least in the early evaluation, in 1 year evaluation, we didn't see in PARTNER 3 something that should limit the use of SAPIEN 3. To the opposite, we see that the composite of death, stroke, or hospitalization was much better with the SAPIEN device. Over the years, the curves became closer to each other, but at least we don't see some problematic signal with that comparison. When we look at the EVOLUTE platform and compare EVOLUTE to surgery in the low-risk study patients, 5-year follow-up, again, the comparison of all-cause mortality or disabling stroke, we see similar numbers, if not a bit better for the EVOLUTE device. Cardiovascular mortality, you can see it in the right, in 5-year follow-up, there is a trend for better outcome for EVOLUTE in comparison to surgery. So we can say at least that there is no signal for harm with using the EVOLUTE platform. Also with bioprosthetic valve dysfunction or bioprosthetic valve failure, no signal for an issue, at least in 5-year follow-up. And when we talk about lifetime management and treating patients, maybe we can treat them upstream. We can treat them before they are symptomatic. So I'm not going to dwell too much on early TAVI trial, but we have some signals to suggest that there is a benefit of treating patients even when they are asymptomatic, when they have severe aortic stenosis. And maybe in the future we will discuss upstream treatment of patients with aortic stenosis before they have severe aortic stenosis, because they have heart failure or other symptoms. And it translates to a very dramatic growth in procedures. The TAVI phenomenon and the TAVI era, with a dramatic increase in cases, and this is becoming not a bit anachronistic graph, but now in the United States, there are more than 100,000 cases performed annually, TAVI procedures, much more than surgically implanted devices. And there are new priorities when we talk about patients at low risk being treated with TAVI procedures. Because in the past, when we talked about treating octogenarians, patients with low level of activity, we focused on procedural success metrics, on mortality, on stroke, on quality of life, on acute success. But now when we talk about treating patients in their 60s, more active patients, more bicuspid cases like we saw in the previous presentation, discussion on how to do it well. We need to think about hemodynamics. We need to think about prevention of prosthetic patient mismatch. We need to think about how we prolong the durability of these devices, and also how to treat them if they fail. So not only durability, but also treatability. What do we do when that TAVI device will fail? How do we do a successful TAVI without going into coronary obstruction risk? Or if there will be coronary obstruction risk, how do we deal with it elegantly with quick procedure, not causing any harm to our patients? When we talk about lifetime management, we need to think about other things as well, not only the durability of the device, but also how to do PCI. Whether the device that we implant will be more complex to perform STEMI procedure with a physician that never implant TAVI devices and has no idea what is that device that is sitting in the aortic port. So need for easy coronary access is important. Unfortunately, we have devices over the years that enable better coronary access. Here, you can say that the Volute FX Plus with the large windows that, especially when you orient them correctly towards the coronary ostia, we have several studies that evaluate it, but naturally, these will improve the success in doing PCI after these procedures. Another thing is commissural alignment. This is a concept that unfortunately, a couple of years ago, we never talked about. We never cared about where we put the device in the short axis, or where are the commissures of these devices and how the leaflets are positioned. But obviously, commissural alignment is one of the most important things to do when we do our TAVI procedures for the lifetime management of our patients, for doing PCI later on, for the hemodynamics of that particular valve, and also for doing TAV in TAV later on, and for doing leaflet modification if needed. Because when there is no leaflet in front of the coronary, when there is a commissure, it's a completely different story. So commissural alignment, I'll not dwell on that for too long, is a very important thing, and that we should consider it in our cases always. When we talk about durability, we discussed it before, younger people degenerate faster by prosthetic valves, and younger people also live longer. A 60-year-old would live an average of almost 25 years later on, and an 8-year-old would live 10 years on average later on. So it's clear that the old patient would require TAV in TAV much less than a young patient, because the young patient will degenerate more quickly and will live longer. So it is clear that in the near future, we're going to see many patients coming with failed devices. There will be some kind of a wave of cases with failed TAVI devices. We need to expect that wave, and we need to understand how to do it correctly. Obviously, when we talk about the lifetime management, there are several sequences of valve replacement that we can plan. Obviously, we can do TAVI. If that TAVI will fail, we'll do another TAVI. And if that second TAVI will fail, we can do a third one. We can talk about the more common combination of doing surgical AVR on a relatively young patient, then doing TAVI, a valve-in-valve procedure in it, and if that TAVI will fail, we'll do a second TAVI. And there are other combinations as well that could be done. Each combination has its benefits and risks, but obviously, we need to think what would be our goals when we talk about lifetime management. What do our patients want? A reasonable aim could be avoiding oral anticoagulation, especially when we talk about Coumadin treatment, and reducing the risk of a need for multiple open heart surgeries. And multiple open heart surgeries, it's a very bad thing to do. So only one open heart surgery and no Coumadin could be a reasonable aim. When we talk about mechanical AVR, obviously we are obliged to use Coumadin. When we talk about bioprosthetic surgical AVR, which could be the common devices or also ROS procedure, then in many of these cases, to be honest, we will find ourselves with a need for 2 open heart surgeries, unless we've started in a relatively older age with the first bioprosthetic valve. There is an option. It's quite unusual, but it is done from time to time to implant a TAVI device in a relatively young age. To start with TAVI, we call it TAVI first. You start with TAVI. When that TAVI fails, you do open heart surgery. You can also have the option of doing TAVI in TAV before the open heart surgery. But you do open heart surgery. And when that bioprosthetic surgical AVR will fail, you do a valve in valve. In that combination, you are able to not use Coumadin and to have only one open heart surgery. The 2 limitations of TAVI first, the main limitations, is that you're going to do open heart surgery after TAVI, which is now, we call it TAVI extraction, which is currently associated with not so good clinical outcomes. And the second thing is that we don't know exactly what would be the durability of TAVI on very young people in the age of in their 40s or 50s. Some of them will have a very complex bicuspid. So this is a very, it's something that we need to learn about in the future. We also need to discuss not only durability concepts, but also treatability concepts. Treatability, our ability to do TAV in TAV. In the past, when devices fail, it was a big issue. A patient that had surgical AVR in the 90s, and that device failed and needed another procedure, redo procedure, that was a very significant clinical outcome. Nowadays, fortunately, we do valve in valve in these patients, and it's less a concern. But still, the treatability of our failed bioprosthetic valves is a meaningful thing. There are some complexities, like we've seen in the case that was presented before my lecture. Sometimes there is a risk for coronary obstruction. Sometimes there is a risk for residual stenosis. So there are limitations for the valve-in-valve field. But in general, valve-in-valve, we do it commonly, like all centers, and we get good clinical outcomes. So these are cases that in many of them that are at a lower risk for complication. We know that in the future, we will see many valve-in-valve procedures. I'm not sure if you've seen that graph. We published it a couple of months ago. In the x-axis, it's the years. It shows basically in blue the number of TAV-in-TAV procedures predicted in the US market. And it is clear that in the near future, we will see many more valve-in-valve procedures, and especially many more TAV-in-TAV procedures, treating failed TAVI devices with another TAVI device. So we must understand what would be the risks of that approach, TAV-in-TAV. It's a paradigm shift. It's not only to understand what would be the durability of our devices, it is also understanding how would be the treatability, or how complex would it be to do the valve-in-valve. And there are devices and there are scenarios that we will use devices that will be, the best thing is that there will be devices that are durable, and if they fail, that they are treatable. This is the best scenario, but unfortunately, like in maybe mitral flow device, mitral flows, we understand now that they are not durable, but they are also not very treatable. In many cases, these cases are at risk for coronary obstruction. In many cases, they are prone for residual stenosis. So this is the spectrum of implanted bioprostheses that we need to consider when we talk about the lifetime management of our patients. And some people ask, can we improve valve treatability? And the answer is yes. There are devices that are easier to treat, and there are devices that are better for valve-in-valve. In general, failing with stenosis is not as good as failing with regurgitation. If we can choose, we can never choose, but if we could have chosen a device that fails with regurgitation, we would prefer it over a device that fails with stenosis. Larger devices are also better to treat. So larger devices and devices that fail more with regurgitation are better. Also, when we talk about prosthetic patient mismatch, valve-in-valve results after PPM is not good. So we need to prevent severe PPM. Severe PPM is something that we should never leave in our patients. So severe PPM, if we avoid it, we improve the treatability of our patients. And we have many tools to prevent prosthetic patient mismatch, and we have strong balloons. And in general, also when we do TAV-in-TAV, in many of these cases, we should, like when we put stent inside the stent in the coronary tree, we never put them alone. We have a strong balloon that will push them together. We need to do the same thing when we talk about the TAV-in-TAV. There are devices that when we think about the lifetime management of our patients that are very successful. For instance, the InSpris device of Edwards Lifesciences. The main limitation of this device, from my perspective, is the fact that it's implanted surgically. You need to do open heart surgery. But it seems that the device has a very good durability, and also it expands naturally when you do valve-in-valve inside it. There is a V-fit mechanism that allows for natural dilatation of this device without a real need for a ring fracture. So it's doing natural ring fracture. This is the InSpris device. One of the limitations, maybe the most frightening one, is coronary obstruction, limitation of valve-in-valve. And we need to identify cases at risk for coronary obstruction. We need to know which cases are at risk and to prevent it by any means, because there are tools to prevent coronary obstruction. And maybe even in the past, we used to say, oh, it was a coincidence. I remember cases that we used to do in America 15 years ago, and we said, oh, there was coronary obstruction. We didn't understand why. It is all about the relationship between the leaflets of the previous valve and the coronary ostium. It is all about that relationship. And you can see in the literature how we define that relationship. We call it type 1 vivid anatomy, type 2, and type 3, according to where the leaflets will go. Type 1, the leaflets will deflect below the level of the coronary ostium. In type 2, the leaflets will deflect above the level of the coronary ostium. And in these cases, we need to measure the VTC. In type 3, the leaflets will deflect above the level of the STJ. And in these cases, you want to evaluate both the VTC and the VT-STJ. This is, in short, how to assess the risk for coronary obstruction. And there is a new field in interventional cardiology, which we call leaflet modification. If in the past we just put a valve inside, or maybe used balloons before or after deploying the valve, now we can treat the leaflets as well. Basilica was the first technique of leaflet modification. Unfortunately, Basilica is a procedure that is complex to do, somewhat complex to teach. I went in around many centers proctoring Basilica. It is not the best thing to do, but it is doing the work, because the origin of the problem is the deflected leaflet. And if the deflected leaflet is the origin of the problem, we need to modify it, change it. And the leaflet modification could be performed with basilica. I'll not go into details on how to do basilica, and you can see it in different papers. When we talk about certain scenarios, basilica could be very challenging. This is a patient with a failed core valve at need for double basilica. At some point, you have 5 catheters in a very small aortic root. This is a complex scenario. We can succeed in these procedures, but it is risky. And there are many devices that will allow for leaflet modification. Already the first approved by the FDA is the shortcut device that I was fortunate to the first cases and work closely with Picardia on that. It's a dedicated tool that allows for leaflet modification. These procedures are relatively easy to do, and they are allowing for leaflet splitting and prevention of coronary obstruction. The first study we published the results a year ago in the European Heart Journal on 60 patients. I'll show you an example from one of these cases, relatively old lady with a failed evolute, and that required leaflet modification for both the left and the right coronary phase sinuses, as you can see. Not very high implantation, but clear risk for coronary obstruction. You can see the leaflets of the left cast and the RCA. And this is the procedure. I show it in short. It was a very short procedure, only 20 or 25 minutes. And later on, you see the split of these leaflets. And after implantation, no coronary obstruction. So maybe in the future, to allow for better treatability of our failed devices, we will require more tools that will allow for leaflet modification. So long presentation. I try to give you different aspects of the topic of lifetime management of patients. But in short, probably when we talk about lifetime management, we need to think about devices that will last long, that will be durable, and will be durable for our specific patient, but also devices that will be amenable for safe therapy, that will be treatable. We need both durability and treatability in our cases. So thank you very much for your attention, and the lecture is open for discussion.
So, Dan, thank you very much. It was an excellent presentation, very informative, complete, I would say, and thought-provoking. So, do you have any comments from the audience? I think it's very interesting that that you need to plan when you plan the first TAVI. Maybe you need to plan on the table the second procedure as well, right? So when we deal with a young patient, let's say a 70-year-old female with a small annulus, what's your main criterion? How do you choose your valve? We have the results of the SMART trial. Hemodynamics are very significant in this population. Would you go for the annular valve, and in order not to have on the second procedure how to deal with the supraannular, let's say, leaflet, or you go directly with placing correctly a better hemodynamically valve and deal with the deformity, the possible deformation down the line with, let's say, an annular valve on a second procedure? What will be your take on that?
It's a great question, and the answer, and it's complex to answer it. But I can say in general, to me, as Danny, when I do my procedures, over the years, I actually try to maximize and to optimize the results of the first procedure. Because when you think about the future and when it interferes with the actual procedure that you do, for instance, it's very common to say, let's say that I'm doing an evolute case, and I'm going to put the evolute 8 millimeter in depth. or 7 millimeter in depth instead of 2 millimeter in depth, thinking about the second procedure. With time, I think that this is not the right thing to do. We need to focus on the procedure that we do now. It's true that we need to think about the second one, but the second one could not happen. It could be in 10 years or 15 years. And the technologies that we'll have in the future to prevent coronary obstruction will be very wide. I'm absolutely sure we will see many devices for leaflet modification. There are already many devices in the process. So for centers that are now treating a 65-year-old and trying to think about what to do, which devices to use, maybe they need to use the device between the two that you mentioned that they are more familiar with, and they have the ability to get out of the cath lab with the best results, with an expanded valve and durable, as much durable results that they can get. But thinking about prevention of coronary obstruction by having low devices, or thinking about coronary access nowadays that we have the Evolut FX Plus that improves coronary accessibility in a significant fashion. I think it's not reasonable.
Exactly. I think this is the point that I wanted to clarify. So there's no the solution to place lower than it should be. The Evolut, it's not a good solution because you end up placing more pacemakers. Maybe you have hemodynamically worsen the valve down the line, and when we place a pacemaker, this has impact on the longevity of the patient as well. So I think this is very important. And regarding you showed very elegantly this case with the FX Plus. In Greece, unfortunately, we don't have the FX Plus. We have only the FX. How much of an upgrade is compared to the FX Plus? So this access to the easier access to the coronaries, how much of an upgrade is that?
So we have access to FX Plus for less than a year. It's a couple of months already, or maybe 6 months. We did dozens in my facility of FX Plus procedures, and not many, but there were several PCI procedures that we performed afterwards. It's working. There are large windows, and actually it only signifies the need for commissural alignment because you need to put the windows of the device in the correct place. But I don't see post-TAVI PCI as a complex scenario that will drive me to use one device instead of the other, as long as I have these modern devices. I hope that you will get access to FX Plus in the near future.
Okay, good. So maybe this will be a game changer for Greece, because now we're in our center, we are doing, we have almost 2,000 TAVI cases. Approximately 92% of these cases are core valve and the Evolut platforms. So we are not worried because I think we placed these valves in a correct, the correct place, and most of them are not under expansion. They're not under expanded. We have a very low turnover with TAV in TAV. But I suppose the wave that you predicted will be here, and we have to be ready to tackle it. This is very important. And we have in the audience George Dangas, Kostas Maragiolis from TAVI Heart Center. Costa.
So I would like to ask you about the alignment of the valve, which is a new concept. To be honest with you, we have done very little attempts for alignment of the valve to completely align the commissures. The question I have for you is two questions. First of all, do you think that the longevity of the valve is related, or maybe the halt incidence is higher when there is malalignment? Maybe the valves fail early. And the second question is, in cases that you're afraid you have very low coronaries, do you at times intentionally try to malalign the valve so you decrease the chance of obstruction? Meaning you try to put the leaflets on the lateral sides of the coronary so you leave the ostium open?
Great two questions. For the first one, about the hemodynamic potential, optimizing hemodynamics of valves by the commissural alignment. There are several registries and publications that show that the hemodynamics are a bit better. It's a meaningful signal to suggest that there is a difference. There are a lot of bench testings showing the potential for better physiology for the leaflets when they are commissurally aligned. Personally, about your second question with the commissural malalignment and protection from coronary occlusion. So if the audience didn't understand, we're talking about malaligning the valve leaflets on purpose in order to have that commissure tab in front of the coronary, thinking that maybe by that coronary obstruction will be prevented. To be honest, and we did a lot of bench testing in that field, we are not sure. It could be that in certain scenarios, having severe malalignment in these cases can prevent coronary obstruction. It's true. But it is also risky because when you do severe malalignment, you cannot do leaflet modification and you cannot go back to the coronaries easily. So you have cases at risk for coronary obstruction that it's very, very difficult to prevent with chimney or with leaflet modification. So it's a complex topic. We hope to learn more in the future.
Yeah, but maybe this, you know, one could consider, you know, when we deal with a 75 or 70-year-old female who has no coronary artery disease factors, no family history, and pristine, let's say, coronaries, maybe this would be a solution in some small anatomy. George, what would you say? Would you do that?
George is brave. Maybe he would do that.
Well, listen, the alignment is always a good thing to try. And if you don't try, the chances is going to happen is over 60%. If you try, it's going to happen about 30%. So it's a good thing to try.
Yeah.
So, you know, and the more important thing is that if you want to change the alignment, you have to retract the valve in the descending aorta and align there. Why? Because otherwise the valve already made, the system already made a curve around the arch. The torque is not transmitting as you think it transmits. So you see it transmitting, and as you move it, it goes back or moves a different direction. Whereas if you put it in the descending aorta, then it moves more predictably, hopefully.
Good.
I think that's one tip I want to say about that. And sometimes we're in rush, and you try to move it while you're still in the ascending aorta, and no wonder it's not going to work so well. It may, but it's not going to work well because of the tortuosity in the iliac and the arch, and prevents the torque transmission.
Good. And one more question. So Danny, what's your preferred approach? So let's say you have an evolute which has dysfunction, and you need to place another TAVI. Which is your preferred platform? Would you place another supraannular platform or an annular or a balloon expandable?
Usually, and it's really nice, these devices work well with each other. A failed sapien is treated well with an evolute, with good hemodynamic result, better than sapien and sapien, and a failed evolute is treated well with the sapien. So at least here we have friendship between the devices.
So there is a synergistic phenomenon, okay? So there's okay.
And also, if a patient failed with a certain device, it's like you can say about coronary stents. use a different stent. Use a different valve.
You change horses.
Yeah.
Yeah, well, I mean, listen, also you have additional valves. Also, you have the self-expanding intra-annular valves that can be used, and you want to learn more about the failure patterns of these valves and what are the options there. The things get more complicated, but it is good to, the advice to use a different valve. I would like that also, because if the first valve failed and try another valve, I think makes some sense.
Okay. Good. So, any other comments from the audience, Dr. Mastrokostopoulos? And maybe you can make a comment. We'll discuss with Dr. Dvir as well about the possibility of damaging the valve with the post-dilatation or the fracture. So, I saw in your case that you had some residual gradient. So, if it's a young patient, maybe we pay that attention as well, because what we measure, maybe it's less than we get to see with the echocardiogram later down the line. So lately we're a little bit reluctant to fracture the valve. Can you elaborate on that? Do you think we are provoking more damage than doing good?
So thank you very much. Great lecture, Dr. Dvir. Thank you very much. So following what Dr. Iakovou said, for me, it's very interesting because when we're thinking about fracturing the valve, so for me, we have to decide from the beginning that we have to fracture a valve that is probably a small valve, because if you look at all the studies, you see that the majority of people have a 21 or 23 millimeter valves, bioprosthetic surgical valves. So in this way, we are starting that we have a true inner diameter of about 19, 20 millimeters. So we're actually thinking about placing a TAVI valve in a 19 or 20 millimeter diameter. So from the beginning, we are anticipating that we are not going to do very well, because this is what we have. For me, in my mind, I think that it's necessary for all patients with a severe aortic stenosis, either having TAVR or SAVR, that they should do a CT before, because we can get information from the CT, from the original CT, because if you have a bioprosthetic valve implanted, you change the anatomy and you will have better information about if you can fracture the valve or you're going to do an aortic rupture. Because it's tight there, we are using a balloon and we're thinking about fracturing something, but we do not actually know what the original aortic root and annulus was at the beginning. So this, for me, is valuable information to know before deciding to fracture. So in our center, we have only fractured 2 valves successfully with no aortic rupture. But I think that now, there are not many fractures of the valves, because we're anticipating and we are afraid of the consequences, because it's either you lose big or you win small, because from the beginning, you have a 19 or 20 millimeters diameter to work with. This is what I think. I don't know what your opinion is about on this.
Well, let me just say something also that we don't talk about it, but it exists. You have to be very clear about how many years after the original valve implantation we're talking about, and how many years has a deterioration been. Because if you're talking about whatever valve that the patient had for 10 years and then it failed, now to tell me that you're going to fracture it, that doesn't make any sense, because the patient was doing very well for many years. So for whatever reason, that valve maybe looks small, but it was working out for the patient. Now it's also older. But if the valve fails early, or if the patient tells you they never got better, or they had problems from day one, but somehow continue to be on diuretics or whatever, then you have a reason. And I think that is a parameter that I use and we should be using all the time. When do you think, if we think the patient had a relief with a 19, regardless of then that was working for the patient for several years. Why mess with that and take a risk?
Okay, so Dan, I think you agree with that. You have any last comment?
Yeah, we mentioned briefly the topic of ring fracture, and I must say it was also discussed briefly in the case that we've seen in the failed crown device just before my lecture. Ring fracture is not shy of major complications, and we should reserve it to the right situations, especially people that large body size with small devices, but with large anatomy that will amenable that and not at risk for coronary obstruction. These cases can improve a lot by ring fracture.
Good. So thank you. We have to leave it there. It was very, very, very informative. So thank you, Danny. Excellent presentation. And thank to anyone that is here. And we will commence the meeting in half an hour from now. Okay, thank you.